Hi everyone, this is Dr. Shantanu Gulati and today I'll be sharing a case where I had the misfortune of a PC rupture during topical Phaco emulsification in a resource limited setting. Now when I refer to a resource limitation, I'm specifically talking about the unavailability of 3-piece sulcus IOLs, which we all know are 3 to 4 times more expensive than standard PMMA or foldable acrylic IOLs. While foldable sulcus lenses are the go-to option in many cases of intraoperative PCR, in situations where they are not available, an SICS incision can be really helpful. As you can observe, a fair bit of maneuvering is being done with the left hand, which is again an outcome of resource limitation in the form of repeated use of reusable tubings that often lose their compliance and result in poor fluid dynamics requiring compensation. Phaco emulsification continues steadily, and once half of the nucleus is emulsified, the posterior capsule appears intact with no defect at this stage. As the Phaco comes to an end, the capsular bag reveals a large horizontal capsular defect. We also notice a small piece of nucleus remnant still inside the bag at 11 o'clock position. At this point, we ensure to keep the irrigation on, avoid sudden withdrawal of the Phaco probe, and perform a viscofluid exchange with the non-dominant hand. A subtenon block is then administered in the inferomedial quadrant to ensure patient comfort. The remaining nuclear fragment is then hooked out into the anterior chamber and emulsified with the Phaco probe. It becomes imperative to not come out of the eye abruptly at any point and perform a fluid visco exchange at each step. A 20 gauge anterior vitrectomy unit is used to perform a limited anterior vitrectomy followed by removal of the epinuclear plate in aspiration mode with controlled bursts of vitrectomy. A superior shelved incision is then fashioned to allow insertion of a rigid PMMA IOL into the sulcus. rigid PMMA IOL is then inserted into the anterior chamber over the iris and carefully dialed into the sulcus between the iris and the anterior capsular margin. The MSICS tunnel is now secured with two 8-0 sutures. The pupil is constricted with pilocarpine, followed by injection of diluted triamcinolone into the anterior chamber to check for any remaining vitreous strands. The vitrector probe, a superior iridectomy is then performed, concluding the procedure. This case underscores the importance of learning and mastering the MSICS incision. Apart from being a beautiful primary surgery, it is also a great skill to fall back on in sticky situations such as I encountered here. Thank you for watching.